Here I have the drill guides in. I'm going to take these out for now because, again, I'm using a saw, and the saw is much bigger than one I use in the operating room, so I'm just going to cheat a little bit. Here we got a counter cut first. Again, the sub bones are a bit bouncy. Made out of plastics. Not typically the way it goes in the operating room, but that's the idea. And then I'm going to line up with the drill holes there. Makes the second part. And I'm going to connect the dots here a little bit on this side. Again, much more crude than the way we do it in the operating room because some of the instruments we have are a little bigger. And then I'm going to take this osteotome here. I'm just going to see if we've got good separation. And in the R, we actually do crack the bone ever so slightly with the goal of being able to move it over without breaking it completely. So I'm going to try to simulate that with the plastic bone. Here we go a little bit here, just kind of loosening it up a little. And bone has plastic properties just like this plastic bone does. So you can actually move it over a little bit and then place it back in place. And then you can see here I've moved the bone over and elevated it. So now the kneecap will line up with the center of the bone. And then typically in the operating room, we'll use 2 screws to hold it in place. And the first one will be in an angle to kind of hold the correction. And the second one will be more straight to create a kind of teepee, if you will. Being on different angles, that prevents it from sliding back. So this is at a different angle on purpose to keep it more stable. And by doing it this way, most of my patients can do straight leg raises in the recovery room, and you can see the correction. And if you saw it before, I'll show you again. This is how it looks corrected. This is how it looks corrected in the AP view. And you can see the kneecap, instead of tracking to the outside where it did before, we now track into the middle.